Welcome to Market Access Today. Get ready to be captivated by expert insights and explore new frontiers. Traditionally, I want to thank Econits for their unconditional support. Now let's get started. Dr. Slaveyko Djambazov will be with me during today's industry talks. Welcome, Dr. Djambazov. He's an independent consultant in health technology assessments, value-based healthcare, and health policy advisory. He holds a master's in medicine and public health, an MBA from American University in Bulgaria, and a PhD in technology assessment. Today, we are hosting him to provide more details about value-based healthcare and perhaps share opinions or expected developments in the industry. But first, I want to give you the floor to tell us more about yourself and your career journey, please.
Hello, everyone. Thank you, Öznur, for having me here at your channel. So it's true, I graduated medicine. I never worked as a physician, but during my career, I built a pharmaceutical plant, many hospitals, a health insurance fund. And after that, my twins were born, and I decided that I cannot work so much. So I built the consultancy, which I'm currently developing with my team. We are mainly focused in improving efficiency in medicine through the health technology assessment and improving the efficiency of healthcare systems with value-based healthcare.
Thank you. We appreciate you sharing your wide career path with us. You appear to have a full schedule, and I hope these demanding responsibilities go well for you. My next question is about value-based healthcare. How can value-based healthcare principles be integrated into pharmaceutical development and market access strategies?
So if you go back a little bit and see how big pharma, innovative pharmaceutical companies develop their value proposition, it started with we have a new indication, we have an unmet medical need, some sophisticated marketing, and this is not enough. In the last 10 years, especially, we've seen the development of health technology assessment, and they needed to provide evidence and proof for long-term value with all this pharmacoeconomic modeling and budget impact forecasting, helping the decision makers make the right decision for the right patients with the right drugs, with the right comparators. But currently, our healthcare systems, they're not in a turbulence, they're in a plane crash. We see exploding costs and not exactly the outcomes we as a society are expecting. So we need a shift, we need a redesign of the healthcare systems. And this redesign is not paying for volume, but paying for value, new ways of payment, like value-based payments, bundle payments, integrated care, geographical reach. So following all these patterns and the main domains of the value-based healthcare, the industry, the pharmaceutical industry, including medical devices industry, they cannot stay away from this. They're in a very good position to be a key stakeholder into bringing value-based healthcare to the societies together with all the other stakeholders. So, of course, this is a very long-term goal, and it's no fun to do. The implementation is really hard. A lot of institutions are trying. Many of them are successful. There are also a lot of failure stories. But within a time horizon of 1 year, 2 years, which are within the budget frames of the pharmaceutical companies, there might be initiatives connected with value-based healthcare domains, which may help also the companies, not only the scientific societies or healthcare providers or decision makers, like optimization of processes through the time-driven activity-based costing exercises, where with the help of the industry, the capacity for patient access can be increased. The others are very frequently, which are used, are outcome measurement exercises, clinically related outcomes, patient-related outcomes, which are useful for building new payment models, but also can be used by the pharmaceutical industry itself, because this is a real-world data which can bring real-world evidence where they can bring to the decision makers and defend their value in a long term. Integrating the care into integrated practice units is also a type of a solution which comes on the agenda of a lot of companies. Diseases like asthma in children, or multiple sclerosis, or rheumatoid arthritis, or indication-based integrated cancer centers like breast cancer, lung cancer. Pharma is interested into that because the shift towards this type of delivering healthcare will impact them. And if they're on the forefront of this innovation, they will be able to lead this shift. If I can give an example, there are many successful examples, but for example, asthma in children. So there are outpatient centers which are treating the children with asthma. I know of a center which treats 1,500 kids. None of them ever went to a hospital. Not because the kids didn't have exacerbations. Yes, they did. But they were treated within as a daily care, as a 2-3 hours stay, no need for hospitalization, which is a total new way of treating it. Usually, these kids in the fee-for-service systems are hospitalized. Or the clinic Diabetes in the Netherlands, where they treat diabetes type 1, kids with diabetes type 1. But this integrated care also prompts for a different type of payment. So we pay for this care in a different way, including the drugs, including the medical devices. So as a pharmaceutical company, you need to have the evidence, but not to the decision makers this time. You have to provide this evidence to the healthcare providers that your drug is going to do better, improve the hospitalization rate, decrease the hospitalizations, improve all the outcomes, clinically related, patient-related outcomes, and this is measured rigorously during the full cycle of care.
Thank you, Slavy. Without letting up speed, I want to discuss some more details on value-based healthcare. So what specific market access strategies can be improved or developed by adapting value-based healthcare?
Again, from the perspective of the pharmaceutical companies, I'm speaking, because in general, from the decision-making point of view, it's different. If we have a top-down approach, there are some countries where we have the top-down approach, starting from the politicians, regulators, very innovative and active payers. It's different. But in most of the countries, it's bottom-up approach. Innovative scientific societies, innovative clinical leaders, champions, pharmaceutical companies, they're the champions of value-based healthcare. And here the pharmaceutical companies are interested first into having robust outcome data. So collecting outcomes and measuring outcomes, analyzing this data is crucial for the improvement of care for the patients, but also it provides a leverage for the companies while negotiating with the payers or any other decision makers. Integrating care into integrated practice units improves care per medical condition, and this integrated care can be seen in many ways. In oncology, for example, integrating the patient pathway. So we start with the mapping of the patient journey, and the integration means that from the moment of symptoms to the moment of diagnosis to the moment of starting active treatment, all this is mapped, and we should find a way to optimize this process and get the treatment faster to the patient. Without the exercise of patient journey mapping, with the time-driven activity-based costing and all the costing exercises, we just cannot do it. Then with the outcome measurement, we know what exactly we are doing. And further, when we gather enough data, we can provide the decision makers with some bundled payment or capitation solutions. Another example is rheumatoid arthritis. Usually it's treated in clinics, but the holistic care in most of the cases is missing in terms of physiotherapy, in terms of psychological support, etc. And it's valid for every medical condition. To start with a medical condition, we need to have enough volume of patients because volume matters. Then you could have a true optimization and a true subspecialization of specialists and added value. So we need enough volume. We need to have a set for outcome measurement. So ICHOM, the International Consortium for Health Outcome Measurement, they're improving a lot the number of sets which they provide every year. Currently, I think they're 42 or something. We are working very actively with them. But even for those conditions where they don't have ready sets, they provide an advice what to use, like in melanoma, for example. So we need to know how we're going to measure it, when we're going to measure it, and this is all should be standardized just to be able to compare. So outcome measurement, optimization of the patient journey, integrated practice units. If we start from there, then we'll be able to develop the bundle payments or capitation or any other value-based payments. I will give you an example with one of the association of the innovative pharmaceutical companies. So all the companies which are treating diabetes or providing solutions for the treatment of diabetes, they gathered, and together with them and the scientific societies, we developed a pay-for-performance program for diabetes. So incentivization of doctors for improved outcomes. So if you're a doctor and you don't want to do anything, you're going to receive the same as you received last year. But if you want to be competitive and you can prove that with the outcome measurement, that with diabetes it's easy to measure, then you're going to get more. And we did also the cost effectiveness and budget impact analysis. So for every €1 invested, the return on investment within 1 year was 1.3 euros. So it's a no-brainer to start it. And there is no opposition. It was led by the pharmaceutical companies. Now we are working with some pharmaceutical companies in the field of cardiology, together with the Cardiac Society, and building like similar programs for the treatment of heart failure and hypercholesterolemia. And as you see, these are medical conditions where also the interests of patient, scientific society, and pharmaceutical companies overlap. And this is it. So hypertension is a major issue, but I cannot think of a pharmaceutical company with hypertensive drugs which is going to jump into such an initiative. But these pilots, they will provide also a lot of experience for scientific societies, for healthcare providers, but also payers. And then it will be much easier for them to develop themselves programs for hypertension or other medical conditions.
Thank you very much. So my next question is, how does value-based healthcare impact different stakeholders in the pharmaceutical industry, such as patients, healthcare providers, payers, and regulators? And what are the potential challenges and benefits of aligning value-based healthcare with these stakeholders' interests?
Value-based healthcare is not a science. It's a methodology. So my students, they understand it in a day and a half, 2 days. So you can easily understand it. The problem is the implementation, and it's very specific. Even sometimes it's not country specific, and it's even among the regions within the country. It's specific. There is no silver bullet. The idea behind value-based healthcare is that everybody wins. Because our systems are not efficient. So anything what we can do for improving the efficiency of our healthcare systems is going to benefit everyone. So first, we need awareness. We need the training of all these people, because even the smallest stakeholders, if they are reluctant to adopt any implementation, and usually it's because of miscommunication, because of lack of pilots, because of a lot of push and pressure, they don't understand it well. They didn't have enough time to ask all their questions and feel safe into this environment, or they are threatened with punishments. If you don't achieve outcomes, you're going to be punished. This is not the way to go. There are basic leadership questions, like in any industry, which are also valid for healthcare industry. So we need first awareness and trainings. All the people should be informed, and there shouldn't be rush. So all the questions should be answered. So value-based healthcare addresses all stakeholders, and everybody is better after these implementation efforts. Nobody is worse, but usually people are reluctant, and they're reluctant because of change, because of misinformation, because of lack of information or poor information. There are a lot of cases around the world which are proof of that. So we have a lot of lessons learned. We just have to reread them and try to implement without rush. That's why when we start some implementation efforts, we always start with pilots on volunteer basis. So who is going to volunteer and try? There shouldn't be any financial risks for any stakeholder. If there is a financial risk, they will just sabotage it. Even if they say yes, they always say yes. Everybody says yes. Even if they say yes, they will sabotage it. So everybody should be on the same page. There shouldn't be any financial risk. There should be pilots on volunteer basis. And let's learn. Nobody starts to design a pilot with the idea of failure. But of course, failure happens. So you should learn the lesson and move forward. And then when everybody feels safe, we move forward. Our experience is that when people are safe, they jump in and they gain competitive advantage because integrating care, improving outcomes for patients, who doesn't want that? Everybody wants it. And then you have the peer pressure. I also want to be part of this. Why didn't you call me? Yeah, I called you, I told you, but you didn't want to risk it. Usually not the leaders are those who started because they're leaders. They don't need to change. But usually those who are on the second or on the third place, let's say, who strive to be the best, who want to gain competitive advantage, they're the champions. And trust among all these players. If you try to do this implementation in a very competitive field, like one clinic interventional cardiology doesn't speak to the other, there is severe competition, it doesn't work. I mean, there should be collaboration. And this collaboration and competition should be in terms of improving value for patients. It's not easy. It's very specific. It's very specific on the people where the stakeholders are, be it payers, pharmaceutical companies, scientific society, healthcare providers, patients. On top of that, all the other stakeholders. But I've seen that when you start to look for, you always find champions and people who can collaborate and drive this implementation efforts.
That was great. I cannot agree more. So thank you very much. So my next question is, how do you leverage your expertise in cost of illness studies and time-driven activity-based costing to address healthcare costing issues? And what are the benefits of combining these methodologies for macro and micro level cost analysis?
Thank you for this question. It's crucial because, as I said before, we are in a very heavy turbulence close to a plane crash with the efficiency of our healthcare systems. Usually, cost cutting is the first measure because it's easy. And cost cutting without outcome measures is very dangerous because mathematically it improves the equation of value, improving outcomes or cutting costs as a numerator and the denominator. But just cost cutting doesn't work. And the truth is that in healthcare, we don't have good data about true costs. The methodologies for costing in healthcare which are used are not studied in any business school. We cannot see them in any other industry. So ratio cost to charges. So the costs are based on the revenue. No, the costs are not based on the outputs. The costs are based on inputs. And that's where the time-driven activity-based costing, where it comes for getting the right costing data in terms of human resources and adding on top of that the direct costs and some overheads. So this gives clear idea about the costing, about the true costs per medical condition, per patient or per target population. But also in some countries, there is a huge gap between what is paid and what the real costs are. And then the conversation starts, okay, costs are higher than the payment, or the payment is very much higher than the costs, or whatever. But then we start with the true data. During this exercise, we also have very good information about the patient journey, and we can optimize a lot of processes and get rid of all the waste that we have. And when I say waste, anything which is done and doesn't bring value to the patients is waste. It's not so easy. You can easily see it, but sometimes it's a regulatory requirement, so you cannot skip it. But then you know it, and it's a very important topic to open with the regulators. What should be changed, because the goal should be improved value for the patients. At the same time, and this is on micro level, patient journey, full cycle of care per medical condition. On micro level, we also have big problem for cost with lack of costing data. So nobody can tell us, Öznur, now what is the cost of a lung cancer patient through either to remission or death. We don't know. We don't know anything about breast cancer. What is the cost of breast cancer of a breast cancer patient? And when a pharmaceutical company brings innovative medicine, also for rare diseases, orphan drugs, a new medicine to the market, they need to provide evidence to the decision makers about what solution they provide and what problem they solve. So if you have a costing study on micro level, the conversation is much easier. And here we're not talking about only the direct costs, which are directly connected with the payer, but also societal costs. So lack of productivity, disability, caregivers, a lot of different costs which are actually happening. But we need this data. It's a research which is done, but it's not so complex at the same time. A costing study for cost of illness can be done between 3 and 6 months, and when you have the model, you can easily adapt it for the different settings and adjust it and adapt it for the country. But then you have an informed conversation, because until now, and in the most of the cases, it's how severe the disease is. Patient stories are shared, and this is the emotional part. But the decision makers, they just need data. I'll invest into this, and I want to know what the return on investment will be, because then we're going to have a risk-sharing agreement with you, and if you don't deliver, you're going to pay. And these are fair relations for me.
We have concluded our interview for today. Slavey, having you here has been a true pleasure. Do you have any last remarks or upcoming projects you want to discuss with our audience before we close up?
Maybe what I want to say is that continuous improvement is better than delayed perfection. So wherever you can do, start it within your capacities, within your budgets, within your business goals, but just start. And it will be a huge differentiator. You're going to get a competitive advantage, and you're going to move the healthcare system towards value for the patients and be part of this journey. Thank you very much, Öznur, for having me.
Sure. Great. So I appreciate you sharing it. Once more, thank you so much for being here with us today. We hope to see you back in the program in the future. And to our listeners, thank you for tuning in. We hope you enjoyed this episode. Until next time, take care and stay curious.
Thank you.